So can you hear me? Are you able to hear me? Those of you who have joined, are you able to hear me? Answer me, please. Do you hear me?
Yes, doctor.
Yes, doctor.
Okay, let me share my screen again. Can you see my screen now?
Yes.
Is it in slideshow?
Yes.
Okay.
Yes.
So now coming to the eye signs in Graves' disease. You know that normally in all of us, the upper eyelid covers the upper fifth of the cornea, while the lower eyelid is flush with the corneal limbus at 6 o'clock. This is normal in all of us, right? Right. We have known that there is a sign called lid retraction. What is lid retraction? Here, you see, there is spasm of the Müller's muscle or the levator palpebrae superioris, causing tension on the upper eyelid, retracting it, such that there is a rim of sclera above the upper limbus of the cornea between it and the upper eyelid. So this is lid retraction, right? It can be unilateral, like in this patient, you see, the right eye here is normal, while relatively normal, yeah. While the left eye has lid retraction, okay? Or it can be bilateral, like in this patient. In that case, it will cause staring look. The patient appears as if she's frightened. Huh? She's staring. There is a rim of sclera above the upper limbus of the cornea between it and the upper eyelid. But the lower eyelid is still flush with the inferior limbus of the cornea, right? How do we test for lid lag? This lid retraction causes a sign called lid lag. I will show you a video. Let me share the video with you. 1 second. One second, I'm trying to open the video first before sharing it. Remember, I told you, whenever a patient is wearing eyeglasses and you want to examine the eyebrows, the eyelids, the eyes, and so on, you ask the patient to remove the eyeglasses. All right, so let me share the video with you. Where is it? Second. Where did it go? Okay. Can you see the video now?
Yes.
Okay, so here the patient is wearing eyeglasses, right? The doctor asks the patient to remove the eyeglasses and concentrate on the right eye, please. You see, here the doctor is examining one eye at a time. You see, when the patient is looking down, this eye is normal, but this eye, there is lid lag, right? And in addition, there is also ophthalmoplegia. Remember, here the doctor is examining extraocular muscle movement, okay? You will notice that one eye doesn't move properly like the other eye. And in that case, particularly on looking up and lateral, there will be diplopia or double vision. You see? Normally, in all of us, the optic axes are parallel, meaning that both eyes should look concomitantly in different directions, respecting the parallelity of the optic axes, right? But in this lady, no. You want to see the video again? Did you appreciate the lid lag and the ophthalmoplegia?
Yes,
Yes,
doctor.
it's clear.
Yeah, you want to see it again, or is it clear?
Yes, doctor, please.
It's
Okay,
clear.
okay, okay. You see, she's looking down. There is a large rim of sclera between the upper limbus of the cornea and the upper eyelid, while the other eye is covered by the upper eyelid, like in all of us, right? And here, you see, when she's trying to look up and lateral, there is discrepancy between the optic axes of both eyes. The same occurs when she's looking down and lateral, okay? This is up and lateral, you see? This is what causes double vision or diplopia. All right? Is it clear? Is it clear?
Yes, doctor.
Okay. Okay, let me continue. All right. Okay. Time. Let me share the slides again. Can you see my slides?
Yes.
Yes.
The slideshow?
Not yet.
No.
Now it's
Now it's in
slideshow.
Okay,
slideshow.
so we have seen the sign of lid lag. And now, what is the difference between lid retraction and exophthalmos? In lid retraction, we have shown there is a rim of sclera between the upper limbus of the cornea and the upper eyelid, while the lower eyelid is still flush with the lower corneal limbus. While in exophthalmos, the whole eye globe is actually pushed outside by the increased intraorbital pressure. Okay, so there will be a rim of sclera above the upper limbus of the cornea and a rim of sclera below the lower limbus of the cornea. Okay, so here on this slide you can see a female patient, middle-aged lady with periorbital puffiness. This puffiness looks different from that of hypothyroidism, obviously, but she has also exophthalmos. If you look closely, there is a very small rim of sclera below the lower limbus of the cornea and a marked rim of sclera above the upper limbus of the cornea. In addition, she has conjunctival chemosis, the red area here of the conjunctiva. Chemosis, not ecchymosis. Chemosis means conjunctival swelling. Normally, in all of us, the conjunctiva appears like a very thin membrane covering the sclera with no spaces in between. So actually, if you stand in the mirror and try, you put your index finger here in the lower eyelid and trying to push the conjunctiva upwards, trying to wrinkle it. If it's not swollen, it will not wrinkle. The same, I simulate that to a condition when you are wearing a body with tight sleeves. If you try to wrinkle the sleeves of the body, they won't wrinkle because they are attached to the skin, right, of the forearm. But if you wear a white coat over the body, the white coat has large sleeves, right? So if you try to wrinkle the sleeves of the white coat, which is not attached to the body, it will wrinkle easily. The same applies to the cornea, right? And usually we look at that at the area of insertion of the lateral rectus, where there is a red leash of blood vessels in the conjunctiva. When the conjunctiva is swollen, this area tends to swell as well. Okay? This exophthalmos may be unilateral, like in this picture. And our colleagues at the ophthalmology department see this very often, right? Or it may be bilateral, like in this picture. It's very obvious. You see, there is a rim of sclera below the lower limbus of the cornea bilaterally, as well as a rim of sclera above the upper limbus of the sclera. Here, the eyes are very red, you see, They are not red because of conjunctivitis, but they are red because of conjunctival chemosis. Chemosis. You see, here, if you put your index finger here and try to wrinkle this part of the conjunctiva, it will wrinkle because it's swollen. Okay? Is it clear?
Yes, doctor.
Okay. Now, how do we detect exophthalmos? There are several methods of detection of exophthalmos. First of all, the one that I told you just now. There is a rim of sclera below the rim of below the lower limbus of the cornea, between it and the lower eyelid. And there is a rim of sclera above the upper limbus of the cornea, above it and between it and the upper eyelid. All right. If you look inside view, you see, the patient's eye globe appears to be protruded. Type, what else? If you try to do the ruler test, if you have a ruler and you try to touch the supraorbital ridge, the cornea, and the maxillary bone, in all of us, we can do that because the eyes, they are not bulging. But in a patient with exophthalmos, you can either touch the supraorbital ridge with the cornea or the cornea with the maxillary bone, but not the 3 points at the same time. Is that clear?
Yes.
This is an important test as well. And the other way is to examine the patient through this technique. You stand behind the patient who is sitting on a stool at a lower level than you, and you look at the patient's eyes from a supraorbital plane like that. Normally, you can only appreciate the supraorbital ridge and the nose. But if there is exophthalmos, like in this patient, you will be able to see the eyeball bulging from underneath the supraorbital ridge, like here. Here there is unilateral exophthalmos, and here there is bilateral exophthalmos. Is it clear?
Yes, doctor.
Yes.
So if you want to quantitate, you want to see how much the degree of exophthalmos is. You want to measure for follow-up, obviously, for follow-up of progression, okay? So we send our patients to our colleagues at the ophthalmology department. They have this device called exophthalmometer with which they measure the degree of protrusion of the eyeball outside the orbit, okay? It looks exactly like the frame that you wear when you go to the ophthalmologist to have eyeglasses made. But instead of putting lenses, the patient is asked to look straight ahead. And here at the corner, there is a prism or a mirror. And the doctor checks at which reading, here there is like a ruler, at which reading in millimeters the cornea touches this reading. All right. Normally, the eyeball should not protrude more than 20 millimeters. All right. 21 millimeters and above means there is exophthalmos. It can be mild, moderate, and severe, as quantitated by our colleagues at the ophthalmology department. Okay? This is ophthalmoplegia. You see, the patient is supposed to be looking upwards, but you notice this eye is looking more upwards than this one, and this will obviously cause a double vision or diplopia. This is another patient with ophthalmoplegia. She's supposed to be looking straight ahead. This eye, the left eye is looking straight ahead, but the right eye is looking down. Of course, she has exophthalmos and she has also extensive conjunctival chemosis with periorbital puffiness. And this is the CT on the orbit of this patient at the level of the orbits in axial cut, right? So bone appears white. So this is the sphenoidal bone with the area of the sella turcica. This is the rest of the bone of the skull. And this is the nose with the nasal cartilage, the intranasal septum, the nasal septum, and the turbinates. Air appears black, so this is air in the nasal cavity and in the ethmoidal air sinus. And air, fat also appears black, so this is retroorbital fat. You can see that it is increased in size. This is what pushes actually the eye globes outside the orbit. In addition, there is also thickening of the extraorbital muscles, the medial and lateral recti and the inferior rectus, Why? Because they are infiltrated with lymphocytes. Okay, all this leads to increase of the intraorbital pressure, pushing the eye globe outside, leading to exophthalmos. Okay, is it clear?
Yes.
All right. Now coming to thyroid ultrasound, a very important imaging modality. A normal thyroid appears like that. This is posterior, this is anterior, this is right, and this is left. Okay? Actually, you look for the landmark in the center, which is this white line here. This is the thyroid cartilage. In front of the thyroid is the thyroid isthmus. On one side is the right thyroid lobe, and on the other side is the left thyroid lobe. Okay? These are the strap muscles, the black parts. Sternocleidomastoid, the sternohyoid, and the omohyoid, etc. All right? So a normal thyroid is uniformly hyperechoic. Hyperechoic means it has a more increased density than the strap muscles. It appears relatively whiter than the strap muscles. Is it clear? Now, again, so the landmark is the trachea in the center. In front of it is the isthmus. And here is the right lobe. This is the right common carotid artery and the right internal jugular vein. This is the right sternocleidomastoid muscle and the right strap muscles. And here is the left thyroid lobe, the left common carotid artery and the left internal jugular vein, the left sternocleidomastoid muscle and the left strap muscles. Again, a normal thyroid looks hyperdense than the hyperechoic compared to the relevant strap muscles. Again, the same anatomy, right? Trachea, isthmus in front of it, sternohyoid, sternothyroid, sternocleidomastoid, right thyroid lobe, common carotid artery, left lobe, longus colli behind it. And here there is the esophagus on the left side. How do you know it is the esophagus? Sometimes you can see the mucosa inside it, and if you ask the patient to swallow, you will notice it moving. You will notice saliva trickling down the esophagus, all right? And here, usually, this is the key of on the inferior corner of the picture on the right side. You can see the transducer, how it is put. This is a transverse cut of a thyroid ultrasound, all right? Again, this is the thyroid, the jugular vein, carotid artery, and the esophagus, you see, right? Carotid artery, right lobe, trachea, and the isthmus in front of it. All these are normal thyroid glands. Now, the typical sonographic features in Graves' disease are the following. Like you see here, a diffusely enlarged thyroid gland. You see the isthmus is thickened, so are the right and the left thyroid lobes. And it is heterogeneous and hypoechoic. It appears more black than the normal thyroid, right? And if you do a Doppler study on the thyroid parenchyma, not on the arteries, the parenchyma, you will find diffusely increased vascularity, this mosaic appearance. This is what is called as thyroid inferno. It is due to increased vascularity throughout the thyroid parenchyma. Is it clear? So this is a typical sonographic picture of the thyroid in Graves' disease. Any problem so far?
No, doctor, it's clear.
Time. Now, let us look at the thyroid ultrasound in subacute thyroiditis. Again, the thyroid appears enlarged, right? Diffusely enlarged with heterogeneous echo texture. In addition, by Doppler studies, there is reduced vascular flow. You can compare it to the previous one. This one is very much reduced, while this one is very much increased. Okay, so this is the thyroid ultrasonographic picture of subacute thyroiditis, right? Now, this is the ultrasound picture in Hashimoto's thyroiditis, chronic lymphocytic thyroiditis. The thyroid gland appears to be hypoechoic. It's darker even than previously. okay, with coarse micronodular echotexture. If you look inside the thyroid, it appears as if there are several small nodules, but these are pseudo or false nodules. All right, this is the typical ultrasound picture in Hashimoto's thyroiditis. Again, this is the transverse picture. This is the longitudinal picture as well, with showing the micronodular texture, hypoechoic. It appears a little bit black, more black than before. Okay? Any problems so far?
No, clear.
All right. Again, another picture of Hashimoto's thyroiditis, the dominant feature here. Again, this is the trachea, the isthmus, the right thyroid lobe. Diffuse hypoechogenicity. You see, the thyroid appears more black than the strap muscles. You see? Indicating absence of thyroid tissue. Some scarring, these scar tissue, okay? And decreased vascularity, but it's not shown here, with architectural damage in an overall enlarged gland. Typical features of thyroid ultrasound of thyroid Hashimoto's thyroiditis. Okay? And here you see the thyroid appears almost black, and it's shrunken with scars, and it's shriveled up with pseudo nodules. You see, these are not true nodules, they are pseudo, false nodules. Whenever you see pseudo written like that, P-S-E-U-D-O, this is Greek for false, and scattered fibrous tissue bands, the white specks, okay, in a small gland. If you measure the volume, you'll find it to be smaller than normal. And this is actually the final stage of Hashimoto's thyroiditis, and the patient is hypothyroid. All right? Okay, I think we would stop here. Thyroid nodules, we can, although there are only 20 slides or so left, would you like to continue, or shall I stop here, as you say?
I think we shall stop here.
All right, yes, okay. But before we leave, I want you please to fill out a survey, like last time, about today's session, okay? Unfortunately, I don't know how many of you there are. I can see only, let me see, I can see only 17 of you, so I expect to find 17 responses, okay? Like I mentioned last time, the survey is anonymous, so you can write whatever you like. I will not be able to know who wrote what, but I need to know your opinion, please. Let me just open the survey and share it with you. Are you exhausted?
Yes.
Okay. Let me share the, 1 second, as it's opening. I will put it in the chat of Zoom. Okay. Where is it? Yes. This one. Okay. Just a second. Yeah. I need to share it. 1 second. Where is the link? 1 second. It's not shared. It's not sharing. It happened. Here. Yes. Okay. Can you see is the chat working?
There's nothing in the chat yet.
There is nothing, yes. Okay. Can you see it now?
Yeah, it's available now.
Okay, let me share my screen again with you to show you the survey. Where is it? This one. Can you see the screen now? The questions are very easy like last time. Can you see my screen? Huh?
Yes,
Can you-
doctor, but we have to request access.
How is that? How do you
I think you
request?
got the email. I
Email?
already requested the access. You got an email from me. Share request for evaluation.
I will get access to each and every one of you. How odd. This wasn't like that with Microsoft Teams. Oh, yeah. Yeah. Yeah, I shared it. Did this happen with the rest of you as well? Huh?
Yes, doctor. Yeah.
Yes, sir. I'm requesting access as well.
You see, this is another cause why I don't like Zoom. See, it wasn't like that with Microsoft Teams. Okay. Dr. Nagwa, could you open it? Could you open?
I requested access. I'm gonna try again now.
And Dr.
Yes, it's
Ayman,
open.
Dr. Ayman, I shared it also with you.
It's open.
Okay. Right. Okay. Yeah. Now I have like four students. What about the rest of you? The rest of you. Incredible. I have to to share it with all of you. Incredible. Incredible. Next time, I will revert to Microsoft Teams. No way. This is lots of time lost, yeah. Lots of time lost. Now all of you can open it? Huh?
Yes.
Somebody still cannot access the survey?
بس دكتور احنا عندنا فعلا مشكلة في مايكروسوفت تيمز.
دكتور احنا فعلا في مشكلة كبيرة في المايكروسوفت
احنا
تيم
مش
فعلا.
بنعرف
احنا
ندخل
بنعاني
عليه
فيه
مع
جدا
أي
يعني.
حد.
عندنا مشاكل كتيرة دكتور والله مع المايكروسوفت تيم فعلا مشكلة
I'm
كبيرة يعني.
suffering with Microsoft. You like me to suffer يعني? طيب يلا. Can you see my slides? I mean my screen? Can you still see my screen? Let
Yes.
me. Where is the form?
Yes دكتور.
طب where's the Google form? It disappeared. Can you see the Google form? Where is it? Yeah, this one. Okay. So I have only one response. Till now, I have only one response. Can you see my slide, my screen? Can you see my screen? Huh? Answer me, please.
Yes.
All right.
Yes, doctor.
Yeah. Okay. Yeah, I agree. Convert back to Microsoft Teams. I agree. Yes, it's too long because I'm revising. Yeah, I'm revising the whole all the diseases. Of course it will be long. We started with the neutral again. Type. The rest of you, please, whoever finished filling out the survey, please don't leave because I'm going to read to you the responses. Of course, each and every one of you know what you wrote, but it's always nice to know what other people think as well, right? All right. How many are we? We are 14. So I still need eight responses, huh? 8 responses. Yeah, this is a lot of trouble for me because you are supposed to be like 35 or 37. Only 15 attended. Huh? And this is bad. Yeah, where are the rest of you? Where's the rest? يلا يلا before it cuts off we have 10 more minutes to go. يلا the 6 remaining. Hurry up please. Hurry up before it cuts again. For the how many time? This is the 5th time or 6th time? I don't remember. يلا يلا the 6 remaining students. Come on.
هو الراجل
6 minutes.
دكتور
يلا 5 more to go. Yes. Who has a question?
هو الكويشنير فين يا دكتور؟ أنا مش عندي
اللي هو ايه؟ ايه هو ده؟
الكويشنير فين يا دكتور اللي
انا
أنا بدخل
حاطه
عليه؟
اللينك في الشات بتاع زوم. chat box of Zoom.
أوكي أي هشوفه حاضر يا دكتور.
يلا يلا يا جماعة.
الراجل بتاع السيستم بيوتروبونين جاب التحاليل والنيجاتيف لا انا بقول كده، بس هي الفكره كانت الاي سي جي اللي كان فيه مشاكل دي كانت
ما غريبة الصراحة.
Can you still hear me? ها؟
Yes, doctor.
Okay. يلا يلا the rest of you. We are still at 9. 5 more to go. Where
دكتور
are
أنا
those
مش عندي
5?
دكتور أنا مش عندي حاجة في الشات.
يا بنتي أنا حاطة في الشات. أنا حاطاه في الشات.
طيب
أحطهولك تاني. أحطهولك تاني. استني.
يا ريت يا دكتور.
شفتيه؟
كده تمام
طيب يلا. حد
شكرا
تاني
يا دكتور.
عنده problem في to access the survey link.
دكتور وانا بدخل على اللينك بيقول لي بس ان هو ما اعرفش، بيقول لي ارسال رساله لطلب الدخول. انا مش فاهم
أيوة click on it and I will grant you it will send
تمام
me.
اوكي.
Is that Dr. Gamal talking? Dr. Gamal Mazou?
يس دكتور منى يس.
Okay. Here you can access now. And
اوكي.
Dr. Asila also. Dr. Asila, you have problems برضو؟ يلا. Can you access now? Dr. Rawan Ragab, can you access now? Huh? Are you able to open? Dr. Gamal and Dr. Rawan and Dr. Asila.
تمام.
طيب
دكتور
okay.
منى تمام، انا
Okay.
هشتغل معاك تمام.
وأنا
Okay.
كمان
طيب
يا دكتور.
now we are 10 يعني 4 more to go. Huh? Four more people. يلا. Hurry up before the Zoom meeting cuts off again. Anybody else having problems accessing the survey link? Huh? Can you please answer me? What is taking you so long? Doesn't يعني the questions are relatively easy, right? What's taking you so long? I'm waiting. I'm still waiting all that time. Can you still see my screen?
Yes, doctor.
Yalla, 3 more to go. Huh? Huh? Come on, we have 5 more minutes to go. It's going to cut off before I read to you the responses. This is really يعني annoying. Do I have to beg you to continue the questionnaire or what? This is really يعني annoying. Anyway, the timing of the session was appropriate. 54.5% agree, 36.4% strongly agree, 9.1%, this is one student, they are neutral. They don't have a say. The duration of the session was appropriate. 58.3% agree, 16.7% are neutral. These are two. And 8.3% strongly agree, 8.3% strongly disagree, and 8.3% disagree. The session was well organized. 75% strongly agree, 25% agree. The content of the session was very clear. 75% strongly agree, 25% agree. The instructor was well prepared. 91.7% strongly agree, 8.3% agree. There was adequate time for asking questions. 75% strongly agree, 25% agree. What did you like most about today's session? The organization, clinical parts, pictures, full English speaking, brainstorming, covering important points in various topics, covered most topics, precise, to the point, comprehensive revision of all endocrine related topics, more pictures, which makes the content more clear, very useful revision. Zoom is more suitable? I don't think so. The detailed explanation of every single detail in the topic, in the topics making sure we all got the point, the interaction, how it compiled the important elements of each topic, brainstorming. What would you like to change in this session? Duration, we can move faster. You should have told me. Unclear parts, MRI pituitary, because we don't have any experience with MRIs at all. This is why I showed you the imaging. Maybe the third revision part, cases and MCQs to briefly revise labs and treatment, if not a big bother. Thank you very much. Great effort is shown. Deeply grateful. Thank you. Moving to teams, please. Yes, I agree to that. Too long? It is long because we have revised a lot of topics. Nothing. Divide the 2 sessions into 3 sessions and convert back to Microsoft Teams. I think so too. Nothing. I think no. Absolutely nothing. Nothing. Yes. 2 more students didn't write their opinions. Tell me who is talking. Yes, somebody was talking.
دكتور بس هي مشكلة فعلا في مايكروسوفت تيم، فهيبقى أنا بالنسبة لي مثلا يعني بحاول كتير ومش بعرف أحضر حاجة خالص عن طريق مايكروسوفت تيم، يعني حاولت كتير والله. في مشكلة في الإيميل، وطبعا يعني مفيش وقت إن أنا أروح لسه الإي ليرنينج، والموضوع هيبقى صعب. فلو حضرتك تكملي المراجعات عن طريق زوم أكون شاكر لحضرتك جدا. يعني أنا آسف على التدخل يعني، بس
وانتوا ليه مش بتسمعوا كلامي؟ يعني انا بسمع كلامكم وانفذ لكم اللي انتوا عايزينه. انا بطلب منكم حاجه واحده بس، تعبوا السيرفي. ليه 2 طلبه محجمين؟ This is very
أنا
rude.
عبيت
أنا عارفة.
السؤال.
when
أنا
I ask
ناديته
you
بس أنا عندي نفس المشكلة ده.
to please fill out the survey, which doesn't take that much time, you just don't يعني ignore it. This is very rude. Otherwise, I will ignore all your requests to continue on Zoom, and I will revert to what makes me happy, the Microsoft Teams. هذه زي دي، صح ولا لا؟ اللي فاضلين ناويين يعبوا السيرفي ولا لا؟ Anyway, thank you for your time. I hope it wasn't too much trouble for you attending today. See you next Thursday, inshallah. Assalamu alaikum wa
Thank you
rahmatullahi
so
wa
much,
Thank you,
barakatuh.
doctor.
أهلا وسهلا.
عليكم السلام.
وعليكم السلام.